the Medical AI Podcast.
Hello and welcome to the Medical AI Podcast, a 30-minute thrill ride of big ideas. I'm Dr. Felix Beecher and I discuss with scientists, innovators and philosophers. Some have suggested that the medical profession is a force of resistance in AI adoption, that it is prioritising the protection of jobs potentially at the cost of patients. Is there any truth in that? Or is the medical profession actually protecting patients by resisting an overhasty rush to AI adoption? With me is someone who is perfectly placed to discuss this, Dr. Jethro Hubbard. He is a GP and he was also instrumental in the introduction of the BMA policy, the British Medical Association, on healthcare AI introduction. Jethro, it's an absolute pleasure to have you on the podcast. A very warm welcome.
Thank you for having me. It's a pleasure to be here.
Good. So Jethro, could you just introduce yourself and where you're coming from on this kind of area?
Of course, thank you. So I'm Dr. Jethro Hubbard. I've been a frontline GP or family doctor for those outside the UK since 2011, and it's now over 20 years since I started work as a junior doctor, taking those first nervous steps onto the wards. I really feel for those who started just a few weeks ago in the UK, coming into this new, rapidly changing environment in medicine. Even as a junior doctor, I could see how the things that we do in healthcare, particularly how we look after our staff, are as important in terms of how we provide quality care as the actual medical practice and providing clinical interventions. I spent more than a decade as an elected member of my local medical committee, including lead for contract negotiations and IT. And I'm sure most people won't have any knowledge of local medical committees. We are regional bodies that represent GP surgeries who provide NHS primary care as small independent providers. So we see all of the issues in implementing changes in care, both from a staff and patient perspective. Over this decade, I've been involved in the introduction of many initiatives, including small and large IT projects. And my focus is on ensuring that they work in the real world and do not cause more problems than they solve. Building on this experience, I also founded a startup, which is called Etho. This is working towards using AI to enhance effectiveness of healthcare teams across a whole system, and it's been trialled in a number of NHS settings. And I've developed an interest in organisational psychology and system thinking that kind of links all of these threads together. Mm-hmm. And this is where my interest in AI has come from. And I really want to see AI done well in a way that actually benefits the entire population across healthcare.
Now, you mentioned there that you've seen dramatic changes in the last 10 to 15 years. How is AI part of those changes?
So I think AI is really only in its infancy within real world medical care. Mm-hmm. We are very much in the phase where we have a few enthusiasts bringing products through to the market, but widespread adoption really hasn't happened yet in a way that impacts daily care. I think there are products in place, but the trust of these products is fairly low from clinicians. And I have real world experience of both being a doctor and a patient using these systems. So I think we're very much in early days. But AI, it is just the latest stage of the change that's going through the delivery of healthcare. We've been going through decades of moving from very much doctor-led, doctor-dominated care through to bringing in other professions and different roles within the system. And this is something that I think AI will enhance and accelerate over time, and that is why it needs to be done in a effective and controlled manner with appropriate safeguards in place.
Yeah. Okay. Well, look, we'll come on to the details on that kind of issue shortly, but let's just address the kind of bigger issues for the time being, and I want to get a sense from you of how scared the medical profession is about AI and how it might impact on jobs within the medical profession.
So I would say, personally, I'm a cautious optimist. As I said, very much in the early days of medical AI, and the fear of the unknown is very strong. I feel that AI will revolutionize medicine, possibly as significantly as the introduction of antibiotics, or even with germ theory, and going back that far to the changes in washing hands and cleaning the wards, those sort of things. AI will be as impactful as that, but it is early days now, and the wider profession, I think, has yet to really have a chance to look up and address this, because on the ground at the moment they are overwhelmed with providing patient care. So looking up at this oncoming train is the last thing on their mind, apart from those few in positions where they can see the potential and the issues. And I think it is important to remember that doctors are also patients. So from a personal perspective as a patient, and as a father with young children who access healthcare services, we're always considering the multiple impacts here, and we have an expert patient perspective as well when there is an introduction of a new service. So as a doctor, I don't feel that my role is likely to be significantly under threat. I think it will change almost unrecognisably. But the need for medical care is growing exponentially with an aging population and increasing ability to treat their healthcare needs. And whether this is a threat to the profession or an opportunity, I think, is a matter of perspective.
So you mentioned there that there is a certain degree of suspicion within the medical profession about AI systems. Now, is that based on experience of systems that might be clunky or not work very well, or is it more a fear of the unknown?
I think this is a fear of not so much AI as implementation, because for years we have gone through the implementation of new shiny systems that have a lot of promise, but are put in place by those in positions of power who have alternative agendas, normally to do with cost saving and making sure that their budgets for the particular financial year or the political period all line up. And it is highly likely that those systems that are actually implemented within healthcare, especially those within the NHS, will be the ones that exhibit the best cost-benefit analysis, not those that will enhance patient care the most. So that's where, as a patient and a doctor, my concern is, if this is implemented very badly and mishandled, it might deepen existing inequalities. So we have a lot of problems within systems where the wealthy can buy extra care if they need to, but the poor are left with whatever's left over. And if I can see a system where we may end up with a very high level AI enhanced doctor-led care, that is only accessible to those who have the means to pay for it, and the rest of the population are left with AI supported doctor light care, which will be very protocol driven, inflexible, and have minimal doctor oversight. And we have seen this over the last few decades, where we bring in non medical clinicians. Often the oversight is there on paper and not implemented as it is supposed to. And we've seen studies showing the impact of this.
Okay, so let's come to the central proposition in my introduction, and that was the somewhat provocative proposition that the medical profession, that there are potentially pressures within the medical profession to resist AI adoption, in order to protect jobs. Now, could you help us understand that and unpack that a little?
So I think that it is natural to assume that when anyone resists something new, they are trying to protect their own position. And we all are capable of trying to defend the status quo. And if we're comfortable with working in a certain way, then that is entirely natural human psychology. But I think you have to balance that with the assumption that any time an objection is raised, that is the core reason for it. The objections that I have seen over the years, and this predates AI for decades, is that when people introduce new processes, often they only have vision of a part of what they are addressing, and they introduce it to people who have a different perspective and can cover areas that they haven't foreseen. And we see this on an annual basis with introduction of protocols from NHS England, our national body. They will bring in a process where they've looked at one tiny piece of a puzzle, and they've not fully appreciated that it impacts the entire picture. And that's where AI it is so all-encompassing that the introduction of its systems within healthcare will need a great deal of examination before they can be put in place, because unintended consequences, when coupled with AI, which is very broadly applicable, will be magnified to a point where they could be extremely dangerous over time. And there'll be short-term and long-term dangers to that.
I suppose somebody who's a skeptic might argue that if an AI system can, in a quite dramatic way, potentially attack an overwhelming amount of workload, then even if it's suboptimal, it still could benefit patients. You see what I mean? So it kind of, I guess it's a very difficult thing to do, to get the balance of oversight and also missed opportunity potentially right. Could you comment on that?
Yes, I think, let's not pretend that care is optimal at the present time, and that there is great potential for AI to reduce errors, pick up problems. I would love to be working alongside an AI system that was able to ensure that I was my best self every day. So a system that could recognize when I'm getting a little bit tired and pick up patterns in my practice and say, do you know what? You've seen 20 other patients this week who had this problem, and you did order this test for them, and you haven't this one. Did you want to order that this time? I think there is huge potential for that. But you have to remember the issues with AI is that it's only as good as the data it's given. And it has this ability to amplify poor data. If you've worked with large language models such as ChatGPT, you know that they can pick up on tiny nuances or miscommunicated text, and they can take you down a rabbit hole that you hadn't really appreciated. And put into the medical context, that can be really quite dangerous. So I think we need to be very mindful that it's the garbage in, garbage out problem. So if you give it poor data, it will pick up on things that are incorrect and then give you an output which is, it takes you down incorrect patient management. And the state of medical coding I can only comment on general practice in the UK, but medical notes are very inconsistent. I've been involved in the introduction of shared care records, and we've spent years trying to work out a way of presenting data in a way that's understandable by humans who can pick through very easily and put in social context which won't be available to AI, and is very important, particularly in primary care. And the quality of current data, and also if you're adding in non-clinicians adding data, then you risk this amplification of problems that I spoke about earlier.
So you led the national BMA policy for healthcare AI integration. So could you just tell us a little bit about that, what that policy is, and the kind of issues that were involved in developing it?
So I introduced a motion to the National LMC conference to highlight the coming issues with AI, and that was picked up by the BMA national annual meeting, for both of those it went into policy. Essentially, my aim with this was to highlight the potential issues to the profession, because I was concerned that AI wasn't getting the attention it needed from medical leadership. We're in a time of crisis essentially within the medical profession because resources are at an all-time low, and the focus is on keeping the lights on at the moment. So the entire focus of our leadership is making sure things are running now and that people don't burn out and are able to do the job. So my aim was to shift focus from AI being a sideline and something that excited enthusiasts focused on occasionally, to the fact that this is likely to lead to broader systemic changes in how medical care is provided, and that it needed to be done in a planned and coordinated way, because this is important. The details of how it's done is really important. If we want high quality, sustainable, safe medical care, AI has potential to do this and scale it and do it really, really well, but the details matter. And currently, the details are handled by the technologists and civil servants, or those in the position to buy products. And the focus of these people is short-term cost-benefit focus, as I've mentioned. So if we don't address this and stand up and put a voice forward and say, look, make sure our voice is heard, and ensure that there is a clinician perspective, but a patient voice as well, because nobody else is going to put forward the patient voice in a way that understands multiple different patients. Individual patient advocates are good at doing that, but you need a perspective that represents the interactions across multiple patients, and doctors are ideally placed to do this. And it is that concern about medical AI amplifying errors due to poor data quality, and it's struggled to bring in the social cues and the other factors that are involved in providing care, particularly as a GP. So I won't go through the dry details of what the wording said, but essentially it was 3 key points. So firstly, if we're introducing AI, we need to enable doctors to challenge the AI outputs and be indemnified to do this. So would you like me to go into a little as to why that particular point is important?
Yes, maybe give an example. Yeah.
So we're at the early stages of AI. So going back to ChatGPT, those errors that come out, and you just say, well, that really wasn't right. Why did you talk about that? And you can't identify where the error has come from, but you know it's wrong. If you have a doctor in a room that has been employed by an organization that says, this is the AI, they are protocol driven, they've been programmed with all of the things we want you to do, and you are not allowed to challenge them, then the doctor is just a body in the room. They're not providing any extra input to that. And also the AI cannot get safer with time. So the AI needs to be able to learn from the doctor and the doctor from the AI. And the reason the indemnity is important is because if I am to challenge what the AI is saying, I also need to be able to stand up in court and justify that decision. We're already in a position in healthcare where if a doctor sees a patient who doesn't quite fit the local guidelines and has a chat with them and agrees a course of action that it's outside the guidance, but they feel is the right course of action at the time, if that goes wrong, you're far more likely to get hauled up in front of the GMC, the General Medical Council, or in front of a judge to justify those actions than if you had simply stepped back, said, it's not me, Gov, the guidance said I had to do this. you are much safer as a professional. So that is where we need to deal with the psychology of the doctor to ensure that they can adequately challenge the AI so that the AI can be safely supervised.
It's a
So
fascinating kind of area, especially when you get cases of AI systems which have been shown by research studies to outperform the accuracy of doctors, right? So, in that kind of case, what would the basis be for a doctor challenging the AI system?
it's it's a really really interesting area that I think you could do an entire podcast on. It's fascinating, but this there is potential for people to get much better at their diagnosis. Um, but we in medicine we are trained to use the watch and wait principle. So often um, things will get better with time, and there are risks with that. But the my concern with the AI algorithm coming through on this is, yes, it will make medical care more consistent and better over time for the majority of cases. But I do wonder if it will do what large language models do now, that deviate to the mean. So you assume that your rare medical condition will be more easily picked up by AI because it's going to make the doctor think about it. But actually, our experience with large language is that it brings people towards the most common answer. So we may end up with a situation where the AI is missing rarer diagnosis because the most common output is the common condition. Um, so how we deal with that is important, and also it's not just about the AI, it's who's programming the AI. So our protocols are already biased towards system benefit and cost benefit. So if we're relying on the AI from a patient perspective, are you trusting the doctor in the room, or are you trusting the civil servant who decided which protocol was put in place? So who knows? So it is very important to have someone who is there in the room who can say, hang on a minute, there's something not right with this. And I think the majority of the time people will go with the AI diagnosis, but they need to go through that process. And in order to do that, they need training and experience. And my view is that the only people who are sufficiently trained to provide that challenge are the doctors. And they're the only ones likely to sufficiently challenge them over time.
Yeah, okay. So this goes to something you mentioned before, which is that the introduction of AI systems could lead us into a situation where less qualified people are essentially running the show within the medical profession. Now, the benefits of that potentially are obvious because you save quite a lot of money on salary bills. But you've got concerns about this kind of model. I say, first of all, do you think we're moving towards that kind of situation, and what kind of concerns do you have?
I would say that we're already there. If you look within both primary and secondary care, the number of doctors providing care is reducing. We're already seeing in the UK that. I am a freelance GP, and 2 years ago I could get work easily. This year there has been virtually no work, and we have unemployed GPs despite the vast need for healthcare. Um, the the issues with this come where you look at how AI could multiply this over time, and the assumption that AI will increase safety and efficacy of the non-medical clinicians. And I have to say, I know I've worked with some excellent non-medical clinicians. So I know a number of advanced nurse practitioners, some PA, so physicians associates, and some emergency care practitioners. And there are those within those professions who I would be very happy for my family to consult with and receive care from for their medical needs. Um, and I've also worked with some doctors and GPs who I wouldn't be happy for my family to be consulted with. So it's not just the different professions. My concern is that the GPs have at least gone through a level of training which gives me as a professional handing over to another professional a degree of knowledge as to what their background level is and what level they have attained, whereas the other professions, you can get to those roles in a variety of different ways. So I've seen a huge variation in the quality of care provided by those practitioners, much more so than I've seen variation with doctors, although there is variation in that area as well. So the cost savings, I feel this is likely to be completely eliminated by the differences in the way that care is provided. I do a lot of urgent care and out of hours GP practice, so looking after people on the weekends and evenings, and we often see that the non-medical clinicians will take longer on cases, and they will also. And it's an interesting insight. I was speaking to so when we're driving around the county doing home visits, I have a driver to assist me and deal with the kit. And they work with the clinicians in a way that individual clinicians very rarely see each other's practice. So their insight is incredibly interesting in this sort of situation. So their observation was that they will tend to, when there is a difficult decision, and this is a broad generalization, that often there is a tendency to wait, and so if there's anything difficult, they won't take responsibility for that difficult decision. They will tend to default to calling one of the GPs to get backup for that decision, which instantly means that you've negated the cost saving there. There is also data. There's a study. I think it's in 2019. Although I can obviously provide you with an update on that, that showed that it is more likely that non-medical professionals would order additional tests. So the premise of the NHS for years has been that it relies on GPs, as I mentioned earlier, doing the watch and wait. So if you see 1,000 people with a cough, there will be some who progress towards serious illness. But if you sent every single one of them for blood tests and a chest x-ray, the system would be completely overwhelmed. So you take a calculated risk as to which ones you will take on based on your observations. Now, we know that AI is extremely data hungry. And my concern would be that, firstly, if you've got non-medical professionals, we've shown that they're more likely to order more tests, but also the AI could be programmed to be risk averse, and that depends on the individual organization. And it would be the similar situation to if you've ever bought a house and applied for a mortgage, and you get a home survey, and it comes back and it says, well, it looks okay, but we'd suggest that you get a dry rot report, a plumbing report, drainage, everything else done, because we won't cover you if we get that wrong. And the more risk averse the protocols are, the less cost benefit we will have from using these systems.
Sure. Okay. All right. Well, look, let's think about the future for a second, Jethro. If you had to look 5, maybe 10 years into the future, what would your best case scenario look like, and what would your worst case scenario look like, do you think, in terms of AI adoption and the issues involved?
So my best case scenario would be one where so from a personal perspective as a GP, I would like to be able to go back almost to the more traditional model of general practice, where I can actually sit in the room and concentrate on the patient in front of me. So that feeling that you can give them full eye contact, you can listen to their issues, and I know that an AI is in the background taking the notes and producing them in a way that is legally sound but can be understood by them, and ordering appropriate tests, flagging up any concerns or issues, and putting in place a follow-up process that is safe and effective, but is also not taking over my thinking process, because we know that humans are terrible at being the emergency brake. So this is something they've discovered with in the aviation industry and with things like autonomous cars. If you put a human in place where they can just cruise, they switch off, they stop learning, they don't develop their skills over time. So we need augmentation, not replacement.
Yeah.
And that makes me much, much more effective as a GP. But from a system perspective, I think the biggest gains will be the cracks between all of the systems. So joining up patient care so that it just flows and the patient gets an amazing experience and we're not missing anything. And where efficiencies can be made in medical care and things can be automated, that is done. But as we've seen in so many technological changes over time, it's likely that the humans involved in the process will move to a different bit of it and everything will get better. So the counterpoint to that would be a future where we use AI to paper over the cracks in the system. We embed protocols that are much more focused on system benefit, cost controls, and working through processes that we've done for decades, which essentially boils down to how do we replace doctors in a way that is as cheap as possible, makes people feel cared for, and we've done the bare minimum, but actually we can focus cash out somewhere else or cut taxes or you provide a low cost service. So that absolute bare minimum, so we don't advance care or do so relatively in a relatively limited manner. I think that is this dystopian vision that we haven't improved healthcare at all. We've just made it cheaper, basically.
And lastly, I mean, based on the current direction of travel, what's your sense? Are we more in the direction of going towards this utopia or the dystopia?
I think we're, unfortunately, at the moment, I would say, particularly in the UK, we're heading towards the dystopia. Okay. The political landscape and within healthcare organisations, there is this panic at the moment that things have been cut over so many years that there's no capacity to actually step back and have the thought of how can we do this better.
Yeah.
Because it will take a lot of reorganisation, and there is this amazingly bright future for medicine, but we're in a position where those running the system are used to firefighting, not looking at the future. So this is why I put this forward to the BMA to try and to put this on the agenda front and centre, because there is an opportunity to do this now. If we leave it for 5 years, we'll be in entrenched habits and systems that are very difficult to reverse. And my impression is that we will be in a position where my utopian vision will be put up against the dystopian vision, because there will be examples of both, and it'll be put through the lovely cost-benefit analysis. And it is similar to if you've ever, I'm sure you've seen Fight Club years ago.
It's and they talk film, Jethro.
Yes. So he has a job where he looks into how much it would cost to recall cars after an accident versus how much it would cost to pay out compensation to all the people who died as a result of the problem going wrong. And they will put it into a cost-benefit analysis, and if it is cheaper, I think it'll still be slightly cheaper to do the doctor-led care, because I think it's the old, if you enhance the top of the system, you get much more benefit from it. I think that the difference will be something of the order of it is 3% mortality versus 2% mortality, and they'll look at that and go, well, it's not worth changing. So that's my worry over time, but I am really hopeful that we can move in a better direction, and we can grasp this now, and hopefully a brighter future lies before us.
I suppose that's going back to what we were talking about before. If you compare it to germ theory,
yes,
that was easy, right? You just had to tell people not to cough everywhere and wash their hands now and then. It's much more difficult to implement this time round.
I think the most interesting thing from germ theory is the studies on the deaths in perinatal mortality. So the fact that it took, I believe it was decades for people to accept germ theory, and the fact that taking your hospitals from doing post-mortems on women who died from infections in childbirth, not washing them or washing your hands and then going on to do caesarean sections might possibly impact the mortality rate of the people you did the caesarean sections on. Right. And it took decades for that to come through.
So, last question, Jethro. What is your, and this is a sunnier question because we like to end on a nice positive note, what's your favourite current example of a medical AI system yourself?
So I was looking through this. I would say that I am, because of my freelance position, I can't implement these. I'm desperate to use them in my general practice, but it is more difficult when you're moving across organisations. But Nabla is an example of something that I really want to introduce. So that is an ambient transcription tool which helps with that vision that I was talking about before, with the ability to just chat with your patient and go through their needs and ensure that everything is correctly going on in the background. And I think these sort of systems are the one that really, really will help people feel more cared for, and that they have got the best out of their consultations with doctors. And that's something that I think will really transform medical care from both a doctor and a patient perspective. The shiny AI in the background and the algorithms and things, they're amazing and they're great, and diagnosis rates will go up and everything will be better. But ultimately, a lot of the time when I see patients, it is about how they feel about the care that impacts how they progress over longer term.
So could you just very quickly give an example of how Nabla might work in your practice?
So Nabla, my superficial understanding of how it works, that you have a microphone running during the consultation, and it picks up on all of the consultations, but manages to miss out any of the pleasantries and the irrelevant bits, and it documents the consultation in a way that is focused on what is needed. So if we have a chat about how you went on holiday last week and you've had a cough and it was it was really bad and I wasn't happy with it, doctor, it just picks out that you had a cough last week and you may have been in a different country, so I need to flag that up and document it in a medically appropriate manner. I think that is the core of the system. Yeah.
Brilliant. Well, Jethro, it's a very important issue. It's highly complex, and it's been a fantastic discussion. So I'm very, very much appreciate it. Thank you very much for coming on.
Thank you for having me. It's been a pleasure.
Cheers, Jethro. Bye-bye then.
Thank you.
Thanks for listening. Ping me on LinkedIn if you have any ideas on new subjects or guests.